All right. Hi, everyone. Thank you for joining us today. Seth Holwerda is an assistant professor in the Department of Anesthesiology. He joined in March of 2020, which I feel like deserves a medal and some recognition of its own. You don't start a new assistant professor position in the middle of a pandemic and not have some recognition there. He earned his he earned his bachelor's degree at the University of Texas in kinesiology, his master's degree in the physiology of exercise at UT Arlington, and his Ph.D. in medical pharmacology and physiology at the University of Missouri. And he was a postdoc at the University of Iowa prior to joining the faculty here in the spring. And if you ever want to talk to someone who will get you excited and also be excited about science in general, I would say you should have a conversation with Seth, because I have never left one of those meetings feeling less enthusiastic about ideas in science in general. And today he's going to be talking about untangling the dysfunctional interactions between cardiovascular and pain regulatory systems in chronic pain. And we agreed before the seminar started, when we were meeting with Anne. Seth said that if you have questions, jump right in. We'd rather have a real-time conversation, and so don't feel shy, but I'll also keep an eye on the chat during this today in case anyone wants to post a question there during or after. And thank you so much, Seth.
Thank you, Erin. I appreciate it. So let's get started. I'm going to talk to you first about what chronic pain is and pain and hypertension. So what is pain? This is an interesting description from the International Association for the Study of Pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. And many individuals report pain in the absence of tissue damage. Usually this happens for psychological reasons. There's no way to distinguish their experience from that due to tissue damage. I bring that right up front, and I want you to keep that in mind as I go through this, because it's important to remember that there's an emotional component to it, and we can't always quantify it thoroughly. So what is chronic pain? It's pain that lasts for more than 6 months. That's the general definition. And about 20% of US adults in 2016 have chronic pain, and higher prevalence among women and older adults, costing the US lots and lots of money. It's a problem. It's a major problem. The categories of pain, there is nociceptive pain, and you can think of it as visceral versus somatic pain. Visceral pain being maybe in the abdomen or chest, and somatic everywhere else. And there's neuropathic pain, injury or malfunction to the somatosensory nervous system, causing symptoms of pain. And this can be peripheral or central. And the thing about chronic pain is that patients with chronic pain, they tend to die from cardiovascular disease. And what I'm showing you here is a follow-up of over about 10 years and the cumulative survival from cardiovascular disease. And those with more severe chronic pain and a much less survival from cardiovascular disease compared to mild chronic pain and no pain. And so why is this? It's hard to put your finger on it, but one thing is for sure, the prevalence of hypertension is much higher among patients with chronic pain. And these are data that I have. These patients are at the end of the road in terms of managing their chronic pain, and they're looking for that last final option. And what I'm showing you here is their diastolic blood pressure on the x-axis and their pain score on the y-axis. And what you can see is higher diastolic blood pressure with higher pain score. And so these are patients with chronic low back pain. This isn't surprising. You might not be surprised if I told you that if your pain is higher, your blood pressure is going to be higher. But I don't think it's that simple. I'm going to talk more about that as we go along. So increased prevalence of hypertension and chronic low back pain. So that's just a brief background, and I'm going to go into the interaction between the pain and cardiovascular regulatory centers in chronic pain. This is the interesting part, because what I just told you is that in patients with chronic pain, they tend to be hypertensive. So they have high blood pressure and high pain at the same time. However, this flies in the face of decades of work demonstrating this phenomenon of hypertension-associated hypoalgesia. That's a fancy term saying that when your blood pressure goes up, your sensitivity to pain goes down. Okay, and this is a well-described phenomenon, and there are several mechanisms that can explain this. One of them is the Bayer reflex. So pain, you have pain signals that are traveling to the central nervous system, and this drives increases in blood pressure. These are acute experiences of pain, and the increase in blood pressure is sensed by the baroreceptors, and that causes a reflex dampening of the sensation of pain. And this has been studied numerous times. It is reproducible in humans and in animals. So let's just look at this in a little bit more detail. Having tissue injury and the sensation of pain traveling to the dorsal horn and primary afferents traveling to the brain. And the first step here is central integration. And so these signals are increasing blood pressure, telling the brain that there's pain. The increase in blood pressure is activating baroreceptors in the carotid and aortic arteries. And this is one mechanism of descending inhibition of pain signals. There can also be facilitation, and that's where it gets very complicated. Origins of descending pathways. There are several known pathways in the brain involved in descending inhibition and facilitation. I want to point out the rostral ventral medial medulla because this area of the brain is involved in sympathetic outflow and blood pressure regulation, in addition to descending inhibition and facilitation. So the question that I have is baroreceptor sensitivity involved in chronic pain? Because if the Bayer reflex is impaired, this may explain a reduction in descending inhibition and constant and chronic pain. So this has been a question that I've have begun to examine. And if we look at large scale population data, this gives us some information about this. Not about the Bayer reflex specifically, but differences between normal people, I'll call them normal, and patients with chronic pain. This was a large study in Norway, and what they did here is they categorized them based on their resting systolic blood pressure. Okay, and they put their hand in ice water, and these patients rated the pain, and that's what's on this y-axis here. And so these participants that do not have chronic pain, their scores were lower as their blood pressure was higher. This is that hypertension associated hypoalgesia that I was mentioning before. And those patients with chronic pain do not demonstrate that hypertension associated hypoalgesia. So there is something there in the cardiovascular system that is not functioning normally in patients with chronic pain. And this is problematic because it impairs their perception of pain, and I think it contributes to cardiovascular disease as well, and we'll talk more about that. So what I want to look at is baroreceptor function in patients with chronic pain. So is blood pressure regulation overall impaired in chronic pain? My hypothesis is that baroreceptor control of sympathetic nerve activity is impaired in patients with severe chronic pain. And so here's my thinking. We have afferent signals traveling to the brain. The nucleus tractus solitarius, or the NTS, this is the first opportunity for baroreceptor signals and pain signals to interact. Okay, this is very important. This part of the brain is very important for blood pressure regulation because the baroreceptors tell the brain that blood pressure has gone up or gone down, and there's a reflex change in sympathetic nerve activity to modulate blood pressure. And if pain signals are overwhelming to the NTS or other areas, this could impair not only perception of pain, but also blood pressure regulation. So the rationale here, baroreceptor control of sympathetic nerve activity is diminished in resistant hypertension. This is independent of chronic pain. This has been shown in several studies. Chronic pain is associated with reduced baroreceptor control of the heart. More indirect measures of baroreflex sensitivity. Also, sympathetic nerve activity plays a significant role in sustaining chronic pain, a major role in inflammatory pain models. And we know that norepinephrine stimulates the immune system to produce cytokines. So to perform this study, what I've used are direct assessments of sympathetic nerve activity. Do this using micronography. And so what this involves is a tungsten microelectrode that penetrates the nerve. With extreme patience, it is positioned just right to record from sympathetic C fibers. And so these fibers, there are ascending signals and there are descending signals. The signals that are descending are muscle sympathetic nerve fibers and also skin sympathetic nerve fibers. And for blood pressure regulation, I can isolate those that are descending and go to the muscle sympathetic nerve fibers, and make those recordings. So I'm not going to go into all of the details of how you get that signal, but it is tedious. This is one of the techniques that I learned as a graduate student. It took about 3 years to learn and become proficient and independent. This is a picture of the micronography technique here. So this is the microelectrode. Those two dots there, that's just a magic marker. As I'm mapping the nerve, I make notes there where I think it is, and I position the recording electrode just right to get the nerve recording. So this is the peroneal nerve here down in the lower leg. And this represents really global sympathetic nerve activity. It'd be similar in the arm if it's muscle sympathetic nerve activity. And for blood pressure, this is a non-invasive measurement of blood pressure using finger photoplethysmography. It can accurately predict brachial blood pressure. And this is important. This allows the investigator to get beat to beat blood pressure waveforms. And so I'll show you that here. This is the nerve recording. And each one of these inflections is a burst of activity going down the muscle sympathetic nerve fibers. It's an integrated signal. So the larger the inflection, the more fibers and the more fibers that are recruited and firing all at once. And so let me just describe the baroreflex here. Simply put, we have the blood pressure recording and the muscle sympathetic nerve activity. These are synchronized to the cardiac cycle because when blood pressure rises, when the left ventricle ejects blood, you get a spike in systolic blood pressure. The baroreceptors sense that, and that shuts off sympathetic nerve activity. And that happens in every cardiac cycle. So A burst of nerve activity can only happen in between um, ventricular contraction. So what you see here in this pattern is that when blood pressure dips, you get a rise in sympathetic nerve activity. And when blood pressure goes up, it shuts off, and then it dips and blood pressure or sympathetic nerve activity goes up. And then it's just a constant back and forth. That's how the bear reflex operates. It's constantly working to maintain blood pressure because this sympathetic nerve activity is causing vasoconstriction to raise blood pressure. And the baroreceptors are playing that role in that give and take, back and forth to regulate blood pressure at a normal level. And so we can quantify the sensitivity of the bear reflex using, I use a weighted linear regression where diastolic blood pressure here is plotted on the x-axis and sympathetic nerve activity is plotted on the y-axis. And so when blood pressure falls, you should get an increase in sympathetic nerve activity. And in these participants, you see that there's a greater probability of nerve activity when blood pressure falls, and nerve activity shuts off when blood pressure rises. And so the slope of this regression represents the sensitivity of the bear reflex. Okay. And what I'm showing you here are 3 healthy controls put together. And these are patients with chronic low back pain. And right off the bat, you can see something's wrong here. You can see that when blood pressure rises, they still have nerve activity, which you shouldn't see. Their bear reflex is not anything comparable to healthy controls. And honestly, this is the first time I've gotten statistical significance with an N this low, an N of 3. Doing these studies, first of all, I have to say that it's difficult to do because these patients are very sensitive to the micronography technique because they have chronic pain. Some of them are not, but many of them are. So to collect the data, it's challenging. But I could tell right away that, yes, their bear reflex control of sympathetic nerve activity is impaired. So let's kind of put this together here. Having pain signals interact at the NTS with baroreceptor signals, impairing baroreceptor control of blood pressure. That's what I was showing you there. And I'm just showing you the summary data here. And this is reminiscent of some other data I have in hand. These are healthy adults where I am assessing their sympathetic bear reflex sensitivity, and they don't have chronic pain, but I induce discomfort by placing their hand in ice water for 2 minutes, and their sympathetic bear reflex sensitivity is significantly diminished. So in what I'm doing here is I'm hoping to illustrate the effect of inducing pain and having the interaction of those signals with baroreceptor signals and the output being a reduction in blood pressure control. So my thought process is that this could explain altered pain perception and chronic pain. It can also explain the propensity for hypertension in patients with chronic pain because of dysregulation of blood pressure as a result of chronic pain signals to the brain. So upcoming studies, I want to assess the extent to which central or peripheral sensitization, or in other words, these primary afferents in chronic pain, they tend to become sensitized to a given pain signal. And I want to know if that is related to the magnitude of baroreceptor impairment in chronic pain. Okay, so let's put this in a larger context. Basically, what I'm going to show you next is everything I know about what's causing chronic pain and see what does this add to it, what we know already. And so first to begin, just to differentiate the difference between acute pain and chronic pain, they're not the same thing. Chronic pain is the result of usually an injury that just doesn't seem to heal. And increases in acute pain sensitivity when low blood pressure. I showed you that previously, not high blood pressure, because normally if you have hypertension, the propensity to develop chronic pain is reduced, and acute pain as well. Sensory processing, reduced conditioned pain modulation. So essentially that is the ability to distract you from your pain. Central sensitization or wind up, that I mentioned that on the previous slide, where those primary afferents become sensitized to peripheral signals. There are also genetic factors, SNPs or SNPs, and DNA methylation, emotional cognitive factors, psychosocial factors. So now looking at this and comparing it with chronification, or the development of chronic pain, which is different. What I'm showing you here is largely the same thing, but you can add some additional factors here, behavioral factors, being sedentary, insufficient sleep, your social support. All these things are associated with chronic pain. But what I'm highlighting here are the cardiovascular factors. This is what strikes me the most, is that it just completely flips. There's evidence to suggest that high blood pressure is associated with chronic pain. I've showed you those data. Impaired barrier reflex function, I just demonstrated those, or at least I hope I convinced you that it's reduced. And there's also evidence that use of blood pressure medications is associated with chronic pain. So this is why I'm interested in cardiovascular factors, is because it just flips. There's something very different among patients with chronic pain, and something dramatic changes going from acute pain sensitivity to chronic pain. Okay, so I'm going to move on to the next section here. Can therapy for chronic pain also improve blood pressure regulation? So I just want to highlight first all of the different therapies for chronic pain that are out there. There are many. Anti-inflammatory drugs, opioids, although opioids now they're being phased out to a large extent and reserved for severe cases. Anticonvulsants, gabapentin, pregabalin, these are very common among patients with severe chronic pain. Antidepressants, physical therapy, exercise, electrical stimulation, steroid injections, psychotherapy, behavioral changes, surgery. The best therapy for chronic pain usually involves more than one of these together. Unconventional therapies, acupuncture, this is gaining traction in recent years. Deep brain stimulation, this is reserved for severe debilitating chronic pain conditions. Neuromodulation, this is what I want to focus on today, because it's really the cutting edge of treatment for chronic pain. Typically for failed back surgery syndrome, you have surgery on your back and it doesn't produce effects that are helpful, or complex regional pain syndrome, and among those that are not responsive to conventional treatment. Over in Europe, it's been used quite a bit for angina and peripheral vascular disease. Now in the States, it's becoming more prevalent for angina. And the demand is continuing to increase. About 50,000 spinal cord stimulators are implanted each year. So let's talk about the epidural spinal cord stimulation for chronic pain and how it works. It's based on the gate control theory of pain, which states that non-painful input to the spinal cord can close the gate, if you will, to painful input. So it prevents painful sensations from traveling to the brain. And I'm going to show you this in a diagram here, where we have first the painful signals here, the red nerves, the C fibers, and A beta fibers here that in the dorsal horn of the spinal cord, enter the dorsal horn. This is the epidural space here, where the spinal cord stimulator is implanted and activates these A beta fiber afferents. And these A beta afferents are sensitive to touch, soft touch, more fine detail touch. And so activating these will antidromically activate these interneurons, inhibitory interneurons that will close the gate, if you will, to these pain sensing neurons. And this has been around since the 60s and used for many years, and it's continuing to evolve. My question that I have is, does spinal cord stimulation influence blood pressure regulation? Because it's proven effective for chronic pain, and I'm interested in the blood pressure question. So the surprising thing is that if you look into the literature and you look at patients with chronic pain that are being treated for their chronic pain, there is essentially nothing out there about their blood pressure. I can't find anything about their blood pressure before and after being treated for chronic pain. It's quite surprising. So I've gone out and done that. I'm going to show you the results here. This is using the conventional spinal cord stimulation I showed you in that previous figure. These are patients that at baseline, this is their pain rating. Of course, their pain rating goes down. This is on a scale of, this is a visual analog scale, 0 to 10. And these are pain ratings from their medical records at baseline within about 3 months before, anytime within 3 months before getting their implant, and within 30 days after getting their implant. So I collected these data from the clinic at the University of Iowa Hospital and Clinics. Interestingly, we see a significant reduction in systolic blood pressure and reduction in diastolic blood pressure. So I published these data among other data earlier this year. And really, I think it's the first that has shown that, first of all, pain is reduced when treating chronic pain, and also that blood pressure is reduced using spinal cord stimulation therapy. And so I have a colleague over in the UK, he's doing some similar studies, and he's showing up to 2 years of reduction of blood pressure following spinal cord stimulation. He just published this last month. Although he uses dorsal root ganglion stimulation, it's a little bit different. It's more of a direct application in some ways, but he's getting very good results. Other than this, I don't know of any studies out there that have published on blood pressure responses to pain therapy. I don't think that this only affects blood pressure. I think it also may influence blood pressure regulation. I'm going to talk about that on the next slide, but first I just want to mention that you may say, okay, well, Seth, that's not surprising that their blood pressure is reduced because their pain is reduced. That seems like a no-brainer. You reduce their pain, you're going to reduce their blood pressure. But I don't really have any evidence in these data showing that there's any direct correlation between their pain symptoms and their change in blood pressure. Their change in pain symptoms could be very similar between those that have high blood pressure baseline and those that have maybe lower blood pressure. Really the main predictor of the reduction in blood pressure was their baseline blood pressure. Those with high blood pressure had larger reductions in blood pressure, independent of their change in pain scores. However, I will say that there's a major limitation to these data because they are all retrospective data. I wanted to do the study before I began a full-on prospective study that takes a lot of resources. I'm going to talk about that though towards the end. But I think this has implications for not just their resting blood pressure, but their overall blood pressure regulation. And we can look at this by using 24-hour ambulatory blood pressure and examining the variability throughout the day. This is important for cardiovascular health because the progression and severity of cardiac, vascular, cerebral, renal damage, independent of blood pressure itself, has been shown to be associated with elevated blood pressure variability when using this technique. And so I don't have a lot of data on this, but really anecdotal data saying that this may be very helpful. I have one patient with chronic pain that has data from one patient. It's not my patient, but data from this patient that I had wear a ambulatory blood pressure cuff. The first day he did not have his spinal cord stimulator turned on. I should tell you that these patients are able to control their stimulators with a remote control. They can turn them on and off and change the settings. And I advised him to not use it for this first day, and had a significant amount of variability in the systolic blood pressure from the morning till mid-afternoon. And on the second day, he used his spinal cord stimulator, indicated in this shaded gray area, and the variability in systolic blood pressure was significantly reduced. So I think this is important because it gets at the question of the Bair reflex and blood pressure regulation, and how spinal cord stimulation might affect blood pressure regulation. And so earlier in the talk, I described the impairment in baroreceptor control of sympathetic nerve activity, and I believe that's highly prevalent in these patients. And I think that the spinal cord stimulator, not only is it reducing blood pressure, but I think it's improving their regulation of sympathetic nerve activity. So to look at some of these mechanisms first, to look at whether sympathetic nerve activity might be involved in the reductions in blood pressure, we did some acute studies where we had these patients with the spinal cord stimulators come into the lab. Okay, I had them keep it turned off for at least 48 hours before they came into the lab. And that's to get some washout from, hopefully enough washout. Based on other evidence, that should be a decent amount of time for a washout. And we come in, we lay them down on the bed, set up the nerve recording that I showed you earlier. We get a baseline measurement, and then we turn the stimulator on, okay? And over a course of about an hour, we see a significant reduction in sympathetic nerve activity. So, however, they're lying supine on the bed, so you're not going to get a major change in blood pressure. So I don't have those data to show you to correspond with this reduction in sympathetic nerve activity. To change blood pressure while you're lying supine, you really need a sledgehammer to do that, so to speak. But when we turn the stimulator off, sympathetic nerve activity begins to go back towards baseline. And just to corroborate these data, if sympathetic nerve activity is going down, this is being examined in the peroneal nerve in the lower leg. Okay, you would expect that blood flow in the lower leg would increase because you're reducing vasoconstrictor activity because sympathetic nerve activity is going down. So we made those measurements, and so this is conductance, basically blood flow normalized to blood pressure. And I was measuring blood flow using Doppler ultrasound in the brachial artery and the femoral artery. The reason why I did it in the brachial artery is because if the spinal cord stimulator is at the level of the thoracic spine, if it's reducing sympathetic nerve activity, it wouldn't do so in the arm. It'd only do it in the leg because it's at the level of the thoracic spine. So the brachial artery was a negative control. And so over the course of the hour, we see a significant increase in femoral artery blood flow, which corroborates the reduction in sympathetic nerve activity. Although the timeline here isn't it doesn't entirely line up. In fact, the blood flow increased within 15 minutes, whereas sympathetic nerve activity wasn't majorly reduced until about 45 minutes. And that suggests there are other neural mechanisms that are involved in blood flow, not just sympathetic nerve activity. And there are other data to support that. But the overall message here is that spinal cord stimulation reduces sympathetic nerve activity, at least in the thoracic spine, placed where it is typically placed for chronic pain. So I also mentioned that their pain scores here during the study did not correlate with the change in sympathetic nerve activity. Again, my colleagues over in the UK, they published similar data just last month, showing prolonged reductions in sympathetic nerve activity using the dorsal root ganglion stimulation. So I'm excited about this because it's very solid data that that demonstrates modulation to the cardiovascular system using spinal cord stimulation. And so just to again circle back to the blood pressure variability question, these data here would explain reductions in blood pressure. Then I showed you the 24-hour ambulatory blood pressure and the reduction in the variability that might it asks questions about the Baer reflex and regulation of blood pressure. And I wanted to demonstrate that, or at least look at that, going back to this technique of the sympathetic Baer reflex sensitivity that I showed you earlier. Again, using micronography, the arterial blood pressure monitor, and getting beat-to-beat measures of sympathetic nerve activity and blood pressure. And compared to the pain-free healthy controls, I showed you some of these data earlier where the sympathetic Baer reflex sensitivity is reduced in these patients with chronic low back pain. And with the spinal cord stimulation, we get this improvement in or an increase in sensitivity in the sympathetic Baer reflex. And this is exciting. These data actually pose more questions than answers, because what happens here actually is this is up at 15 minutes, and over the course of an hour, it actually begins to reduce. It's reduced back towards baseline rather rapidly by 45 minutes, definitely. So again, this is the conventional spinal cord stimulation where it is a low frequency, and we can't do control conditions because these conventional spinal cord stimulators with the low frequency produce a paresthesia, and the patients can feel the tingling. Sometimes they'll describe it as something else. Basically, they know that it's on because it's masking the pain with its paresthesia. And there are newer technologies that are being used heavily here at KUMC using high frequency stimulation. And I'm going to be doing some studies examining this with the high frequency stimulation to determine if we can get longer lasting improvements in sympathetic Baer reflex sensitivity using the high frequency. Okay, so I'm just going to summarize everything here. Last data slide. If I was to give you just one take-home message, I would say there's collateral improvement in blood pressure regulation with spinal cord stimulation therapy. And this is how I propose that it's working. We have perhaps a tissue injury, and that's signaling to the spinal cord. These primary afferents are signaling to the brain. Now with chronification, something happens here where the central nervous system becomes sensitized, or there's peripheral sensitization. There could be a variety of issues, but in any case, the spinal cord stimulation therapy is blocking these afferents. And so what that is doing is it's blocking the signals to the nucleus tractus solitarius, among other places. What it's doing is it's reducing the interaction with these augmented pain signals with the cardiovascular regulatory centers, and it's allowing the baroreceptors to operate more efficiently and have better control of sympathetic nerve activity and blood pressure at the same time while it's reducing pain symptoms. Now, what I'm going to move on to pretty soon is determining whether the spinal cord stimulation therapy is improving baroreceptor inhibition of pain. There are a lot of questions still unanswered, but I believe that these data so far provide a strong rationale for our upcoming studies, which I want to describe on the next slide here. So this is our study right now that we are recruiting for. We have others in the pipeline, but right now we're recruiting for this one. We call it the ESCAPE study. The primary aim is to determine significant biomarkers for spinal cord stimulation mediated reductions in chronic pain. I talked about the influence of chronic pain and spinal cord stimulation on the cardiovascular system. That's great for reducing cardiovascular disease risk in patients with chronic pain, but we also want to address their chronic pain symptoms. And the most difficult part about treating patients with chronic pain is knowing how they're going to respond to therapy and what therapy is going to be best. So I want to do the study to look for biomarkers that will help predict the responses to spinal cord stimulation therapy. So the hypothesis is that impaired blood pressure regulation, i.e. the baroreflex at baseline, is a significant predictor of improved pain management following spinal cord stimulation therapy. This is really actually, I lumped several things into here. Impaired baroreflex sensitivity, also increased ambulatory blood pressure variability, and also hypertension. So I want to look at these things and their ability to predict reductions in chronic pain using spinal cord stimulation therapy in a prospective manner. Nobody has done this yet, and these are the data that I really wanted to get my hands on. So this is what we're doing for this study. The inclusion criteria are fairly wide open compared to a lot of other clinical studies, because for one thing, these patients often have quite a bit of comorbidities, and it becomes a very sticky situation when you begin excluding patients for things. But certainly we are excluding for history of neurological diseases, because this has a heavy impact on the cardiovascular system and would confound the data. Also with stroke, current diagnosis of cancer, we just don't know how these things would influence the results. I'm including patients with cardiovascular disease because I want to have a subset of data to address that, determine how spinal cord stimulation therapy may improve markers of cardiovascular disease. So we're in the very, very early stages of this. We just started recruiting, and we had our very first patient start the study last week, actually, last Friday. And this is what they're doing. There are 4 visits, and they're all the same. At baseline, they come into the lab. We're getting a blood sample. We're in the blood sample, we're looking at markers of inflammation, catecholamines, assessing blood pressure and baroreflex sensitivity, making assessments of carotid artery compliance, and other assessments of the vascular system to maybe explain their hypertension. And of course, questionnaires about pain and disability to thoroughly quantify these. This has been a limitation of my previous data. not having thorough questionnaires about pain. It's very difficult to assess, and I've had to rely heavily on Andrea Nickel, a anesthesiologist in the department, for help with this, and the 24-hour ambulatory blood pressure monitoring. And they'll do the very same thing 7 days after they get their implant, 4 weeks after, and 8 weeks after. And not all of the patients will have success with their spinal cord stimulator implant, and so they'll get a trial lead. If it doesn't work out, then they won't get it. That ratio, I would say, is probably here at KUMC, 80% have success, 20% roughly do not, something in that ballpark. And so those that do not, we're going to keep them in the study and continue to study them and use them as a comparator for those who do have success. So that's a rundown of our current study. And I just want to acknowledge here, this is funding that I had as a postdoc last year. I finished my postdoc at the University of Iowa last year. And acknowledgements, Dr. Khan, my department chair, I want to thank him for collaboration and assisting in patient recruitment. Dr. Syed and his collaborations with me. Dr. Holland, he was at the University of Iowa with me. He's a neurosurgeon that really got me started with all of the spinal cord stimulation stuff. And we've had, if anybody wants to talk about it later another time, I can give you a very interesting story about how that all began. And Gary Pierce, my postdoc mentor, Davina Klon, she is a new clinical research coordinator that has come into my lab and has just done an outstanding job so far. And I think she will continue to do an outstanding job. And I also want to thank the CTSU, where my lab is located over at Fairway. They do a fantastic job over there. And so I'm going to end with that, and I'll take any questions.
Thank you so much, Seth. So anybody who would like to pipe in, has a question, feel free to unmute yourself or to post in the chat. I'll keep an eye there, but I am going to take the liberty, I'm going to do Kyle's move and take the liberty of asking the first question, just because I'd like to hear your thoughts on whether or not you think that the primary benefit of things like mindfulness meditation or like sensory deprivation may be on chronic pain, may actually be related to the changes in blood pressure that you see that I think, you know, correspond a lot to those other like cognitive type of interventions. And do you think that it's really about the reduction in blood pressure? Do you think those things are happening in parallel, maybe both?
So that is the psychological role in chronic pain. You can't get away from it. I'm glad you brought it up because you can't get away from it. That's why I mentioned it on the very first slide, is because emotions and cognitive factors are infused into this, and I considered having a mindful meditation or some other conventional treatment to include in this study as a comparison to the spinal cord stimulation therapy, because that's needed. It's to me, it's one of the first things that comes to mind. And how do we separate, getting to your question, how do we separate the effects of the spinal cord stimulation from the psychological factors in terms of the changes in blood pressure? That is extremely difficult. And I don't have an answer for that, except for having the intention to include that as a control arm in the study. And because I do think that my personal opinion is that it plays a role, it plays a significant role in changing your beliefs about pain has shown to reduce symptoms of chronic pain. So yeah, great question.
Thank you so much. Anyone else?
I have a question, if you don't mind.
Hey, Doug.
I so I'm gonna guess that you have talked to Andrea about diffuse noxious inhibitory control, or DNIC. Have you talked to her much about that? Are you familiar with DNIC?
I have not talked to her about that yet.
So DNIC is, in my understanding, is that if you have pain, it can be inhibited by other pain, and this is a mechanism to sort of test the central contribution to controlling pain. And Kyle and Eric can probably clean up my opinion of this, but essentially, you can induce pain and then give a second stimulus in a second place, and that second stimulus will be diminished because the pain system
Yes.
will inhibit subsequent pain. And I'm wondering if that's driven by, in part, blood pressure changes that you're seeing. So the first stimulus would surely elevate blood pressure as a response to that. And then through central connections through the NTS and then descending inhibition, I'm wondering if that's driving a lot of the response to the DNIC is just through blood pressure changes associated with that first initial stimulus. Does that make sense?
Yes, and now that you explain that, I am familiar with what you're talking about. It's a different term though than what I know it has different terms to describe it, but that's a great question, and I could test that.
Right.
It can be tested in the lab. It could be as simple as using a cold pressure test where you're putting your hand in ice water to test to stimulate C fibers, and at the same time you do that before and during maybe mental arithmetic. I've done these things in the lab, and so you're being distracted from the pain, and it gets when you're talking about blood pressure and sympathetic nerve activity, it gets in terms of, it's been used quite a bit for pain symptom, or for describing pain and perception of pain, but it'll be very interesting to do that while looking at blood pressure and sympathetic nerve activity, because the responses there's a large amount of debate out there about why some respond, their blood pressure goes up to stimulation like that, and some people their blood pressure does not go up, or their sympathetic nerve activity goes up or does not go up. And so there seems to be these responders and non-responders, and nobody has a clear answer why. And but I think I think you're right. It's a good way to get at that central sensitization question, and I'm gonna have to really think it through to do those studies, because I don't know. First of all, I don't know how. We're still trying to figure out why some people they have blood pressure increases and some don't.
Yeah.
Well, maybe it's genetic.
Right. I knew that was
Yeah.
coming.
Expect that from Aaron, sure.
Right.
I have a quick question. Well, not quick, if I may, Seth.
Sure.
So in my conceptualization of the world, inflammation, and particularly chronic inflammation, is essentially the root of all evil. And specifically in the cardiovascular patients, there is problems with inflammation, in chronic inflammation, where leads to all kinds of problems, including hardening of the arteries. And I'm wondering if patients, in particular chronic pain patients that also have cardiovascular disease and are not showing this hypertension, if I say this right, hypertension induced hypoalgesia, are suffering from a problem related to the inability of the vasculature to expand correctly. So if you have hardened arteries, they're not as elastic, they can't expand as much. And so perhaps there's a feedback loop that's telling the afferents to drive these things harder and harder and harder. And if that's not something like an autocrine type feedback loop where that's just these afferents are releasing more and more chemicals in neuroactive chemicals into that space that serves to sensitize themselves and conduct information back, and then you have this setup like this chronic pain loop that's on top of this inability of the essentially cancels out, right? So you have pain signaling on top of this inability for these the vascular to distend. Does that make sense?
Yes, and I like how you think, because I'm right there with you. What I have in this study is that first I want to get these markers of inflammation. We do that a variety of ways in the blood. But to get at your question, I have those same thoughts. And so the thing is about chronic pain, those in the world of chronic pain, I don't know anybody else who does vascular work as well. I came from a vascular postdoc lab as a vascular lab as a postdoc. And so I'm going to include those measurements, the carotid artery compliance. And so this is a measurement of the ability of these large arteries to distend. And it can assess the compliance of the artery. It can also inform about the sympathetic nerve activity, because the carotid artery compliance, that is the compliance of the carotid artery where those very, very close to where those baroreceptors are. So if the carotid artery is stiff, then presumably these baroreceptors cannot distend and the baroreflex is impaired. And so you have an outpouring of sympathetic nerve activity that's driving inflammation, driving pain. And so I think that's a key piece in this whole picture here of what's going on.
Thank you. I'd like to point out that you're the first person here that's ever said that you like the way I think.
Aw. Well, does anybody else have questions?
I just have one quick question. I don't know if there's a quick answer, but Seth, just kind of tell me the difference between the low frequency and the high frequency stimulation in terms of pain control. I know the low frequency is like a really heavy low rumble that patients get a paresthesia on, but I don't think the high frequency does that. Is that right?
Yes, that's right. And I'm excited to do these studies with Dr. Syed, Dr. Khan, and others, because they only implant high frequency. So the low frequency is generally in the range of 40 to 100 hertz, something in that range, where this high frequency is like 1,000 to like 10,000. And so with the low frequency, you get that paresthesia, and the patient know that it's operating. The high frequency is it is impeding those pain signals without creating paresthesia, because it's at such a high frequency. If you ask the anesthesiologists here, they would say that the high frequency is more effective than the low frequency. It's debatable in the literature that it's more that I've seen studies that a head-to-head comparison of high frequency to low frequency, and many patients say they like the low frequency because they know that's working, because they can feel it vibrating, and there's a very cognitive part to that. Whereas the high frequency, I like the idea of high frequency because as a researcher, that gives me the chance to do some control studies where I've got it working and acting, and the patient doesn't know that it's working. So it's very valuable to me as a researcher. Whether it's, I think that the high frequency, yeah, I mean, that I didn't go much into that during the presentation, because that's a whole nother presentation in and of itself that honestly I'm not I shouldn't even be giving that kind of presentation quite yet. But yeah, that's a great question, and it's going in a lot of different directions right now, because we have the high frequency, And there's a company, Saluda, here at KUMC. Next month, we're starting a trial using this closed loop spinal cord stimulation, where it's giving this biofeedback and making continuous adjustments to based on how the it's detecting how much of the nerve fibers surrounding the electrode are being stimulated, and if you change position, the body position, and then the stimulation goes away or it's overly stimulated, it'll adjust to that so that it keeps this continuous monotone of stimulation. And so the technology is it's advancing quite a bit. I think it's kind of like that hockey stick effect in recent years, whereas the past 40 years, it's kind of just been this low frequency that's always been used.
So maybe this is not the right talk to ask this question, but I've always wondered how the high frequency stimulation works. The low frequency makes sense. That's within the range of firing frequencies for neurons, whether they're afferents or somewhere in the spinal cord, interneurons, whatever they are. But when you start getting into those kilohertz range, that's well beyond the firing capabilities of I think every neuron, especially even during things like epileptiform activity. And I've wondered how that works and if it's similar to like mechanistically to like LTP saturation, where you just blanket the whole system with activity, and then maybe that creates kind of a compensation where you have, like in epilepsy, where you have massive release of GABA or something like that that turns these circuits off. Do you have any idea how this works and how that might tie into what you're seeing in the lab?
Well, so that the low frequency is based on this gate control theory, and from what I understand, the high frequency it throws that idea out the window. I could be
Yes,
wrong.
it does.
The short answer is I have no idea. And the most amazing thing, when I first was introduced to all of this, Dr. Holland at the University of Iowa, I was talking to him, but my very early stages of this, I was asking him, so how does this work? And he said, I don't know. And he does a laminectomy and puts these things in. He'll say, I don't know. A lot of them, even the manufacturers of these things, they don't know exactly how it works, but they know that when they put it in and they make the adjustments, it helps the pain. And so, yeah, I was just floored when I heard that, and that, to me, that makes it all the more interesting. Although I'm one to always want to know how everything works, and I get frustrated if I don't understand how it works. But I don't fault myself here, because even the makers aren't totally sure how it works.
We, in a former life, I was doing some neurostimulation type work, and we found that very slow, very low frequency stimulation would produce very long lasting analgesic effects. Granted, this was in rats, but and then if you pick that frequency up, the higher the frequency got, the worse it was, and you actually could induce pain. And we thought central sensitization. And when we would talk, the manufacturers would come and talk to us at conferences, and it's just completely opposite. And it floors me every time. I have no idea how that works.
Yeah, I agree.
All right, guys, I think we have to let Seth go on his way. I don't want to hold him up anymore, but I so appreciate it. I feel like the conversation is really interesting, and I feel like the individual differences that you see in your data are just really interesting because of you may be able to use them to both predict who would best benefit from some of these interventions, but also those who would not, and who would actually be better candidates for another mechanistic intervention type. So I feel like it's going to be really important for stratifying patients based on what they would respond to best.
Yes, thank you for having me. I appreciate it.
So thank you so much. And everybody have a great holiday, and we'll see you soon.
Thanks, Seth.
Thank you.